Hello, everybody. My name is Amanda Oakley. This is the panel discussion for session 5 at the World Congress of Teledermatology, Imaging and Artificial Intelligence for Skin Diseases. And our session is about global teledermatology. I'm very pleased to be joined by panel members Carrie Wannett, Jules Lipoff, Christian Grice, and Eugene Tan. So welcome, panel members. Very nice to hear your excellent presentations. So anybody who's listening, please send questions and we'll be pleased to answer them if we can. So I'm going to start off, and I'm going to ask Jules a question to start with. Jules, in your talk, you talk about the digital divide, which I think is terribly important. And in my own teledermatology, we're terribly conscious of this, that teledermatology is great for some of us and doesn't work at all in other circumstances. What's your experience?
Sure. Well, first, I just want to say how thankful and grateful and honored I am to be speaking at the World Congress and to be speaking with all you as esteemed colleagues. And I apologize for my hoarse voice. But yeah, the digital divide, I think, is a really important thing to talk about. I think pre-pandemic, I personally had not given it much thought. I think the assumption was that telemedicine is a means to increase access to care. So adding it should only improve access for everyone, right? Maybe we're being a little naively optimistic, right? But in practice, that's only true if everyone really has equitable, equal access to the technological resources to get that access. So even though it should improve options for care, in practice, the most resourced people, the rich, connected people, take up more than their fair share. And then certain groups of people, certainly minorities, certainly more rural populations, poor, we know statistically are much less likely to have broadband internet access. Telemedicine also tends to be in English-based formats exclusively. So anyone who doesn't speak English as their primary language is at a disadvantage. And a lot of people don't have Wi-Fi at home. They only have, they're dependent on their smartphone for internet. And since we've become more video-based during the pandemic, as opposed to store and forward, that has required a greater bandwidth than we had previously expected was necessary. So in practice, I mean, it's hard at a micro level to really see it play out, but I know even here at Penn, there was a study in cardiology actually for telemedicine that they compared the types of patients and insurances of the patients who are seen in their normal clinics versus by telemedicine. And there are fewer Medicaid patients, meaning the poorer patients on government support that were getting seen by telemedicine. So it suggests that actually the people that need the most help are actually still getting crowded out, even though we intended to use this to overcome such barriers.
Well, we've all got our different systems of running teledermatology. And I know in my region, we've been doing teledermatology for I suppose it's 26 years in one form or another, but it was a trickle for a very long time, and now it's a flood. We have 30 to 50 referrals every day through our electronic referral system, and that's basically how we do teledermatology. And we're now unable to cope with that. But I'm quite sure we miss out on a lot of patients. So Carrie, let's bring us into your experience in Africa, because I was rather surprised that your figures from your African referrals is actually you have a very manageable and very low uptake, really. And is that because of some of the digital divide issues that we've heard from Jules, or is it something else in Africa?
Hi, well, I also just want to echo Jules' comments that I'm very delighted to be part of this wonderful conference, and being able to connect people from across the world is a really special occurrence. And I think that part of the work I do in Africa is also sort of thinking about sort of our dermatology care on a global front. And I think the slow uptick has to do with the timing of when we launched the platform in terms of relationship to what was going on in their own clinics. I think the type of platform we're using is provider to provider, and those providers in clinic were having a shortage of other clinicians. And so to add on something else for them to take photos and upload and then follow up was quite difficult for some of them. So I think that's number one. I think number two, in Niger, I think some of the divide, the technological divide did pan out because they had very poor access to internet and such that it would not be able to accommodate any images, and uploading would take such a long time. And so that's why with that collaboration, we've actually now switched to WhatsApp, which is a lot more fluid, and they can sort of provide those on a little bit more of a streamlined basis. And then within Tanzania, I think that part of it is also properly divided too, if things are taking a little bit longer, and trying to find a platform and an ease, try to incorporate it into their current clinical structure to help take care of patients. So I think there are multiple factors that have to do with that. And then certainly with COVID hitting, a lot of the providers, as well as patients, were in a lot of survival mode. Whether or not they weren't coming to clinic, they had sort of a dramatic decrease, as I'm sure we've experienced in our clinical settings, as well as once they did come back, then they were inundated with very ill patients. And so a lot of the dermatologic conditions sort of fell down in terms of that. Our IRB actually was just approved to sort of study in this in a more robust manner. And so even since that has happened and sort of now that things are stabilizing, we've already seen an uptick in the number of consult cases. Certainly not to the same extent that you have in your clinics right now. And I'm almost hoping we don't have the floodgates open to that same regard, but that's part of the experience that we've had.
Yes, I'm a volunteer for Médecins Sans Frontières, so that's Doctors Without Borders, and also for Swinford Telemedicine. I find this very challenging because the referrals are often poor quality referrals, poor quality images, not always, conditions I've never heard of or don't know how to manage. And there is no follow-up. And I think that's, what's the point if you have a no follow-up? And so that I think the fact that the patient disappears, they don't need a specialist to assist them next week because they're never going to see the patient again.
No, I would agree with that platform. And I think Dr. Lipoff also participates in that platform. That's one of the frustrations I have with that as well, because you don't know what happens most of the time, or you may want additional follow-up and information. That's why I think like the collaborations I have where I know the providers more actually can get some of that follow-up if they come back. Sometimes patients leave in the United States may not come back. I assume it's because they're doing better, but it's probably not always the case related to that.
No. The outcome could be almost anything.
I think I'd want to just chip in a little here. So
Please.
Yeah, since I've had some experience and I've worked with the MSF platform, I think it does speak to the power of even a little advice for a limited setting, what difference you can make. For instance, I've had the experience of saying, give that syphilis patient penicillin, and that one instruction can make a huge difference in that patient's life. And that's it. You don't need follow-up necessarily. But it also speaks to why it's important to set up regional interconnected networks so that if there is a way for, to use the system as triage so that the patients that needed in-person evaluation were somewhat closer if they had to travel some distance, that would be ideal. It's not ideal to have like African countries dependent on Western doctors a continent away. Obviously, it's better than nothing, and it's a good way to bridge to that eventual future. But the goal would be to have a network of specialists distributed throughout the world equitably. And this is just the way to slowly maybe redistribute resources as best we can in the meantime.
Yes, I'm sure it's better to have local providers than those of us from a million miles away that have no idea of the local setting.
May I also
availability.
May I also add a question to the technology side? So my part today is about German-speaking countries, but still we had some experience also with our web-based platform in Ethiopia actually, and we realized that internet doesn't work for web-based platforms. What is your experience? Is there a big difference in between web-based platforms and actually native apps? As you mentioned, you're using WhatsApp as a native app, but also if you want to use a teledermatological platform, do you have better experience with real native apps, or can you also work with web-based platforms?
I feel like for the collaborations I have, the native apps are much more easy for them to use because it removes the reliability upon the internet. So just in the initial period of time, sort of as Jules sort of was alluding to, sometimes it was just that they had a need. And so we were trying to initially just fill that need with the resources we had available with the africa.telederm.org app, website, and then really transitioning to what is more sustainable for them in our needs assessment, right? So their needs are having a native app that's easy to use, that can be more streamlined into their workflow, easier to use, so because it's not reliable, reliant on internet, I think is really important. And then certainly partnering with people who are there in the environment to sort of figure out. We've sort of identified some people within the local community who have interest in technology and making it more sustainable. And so I think that's really important. And then of course, partnering with those providers who are in the area. And so certainly the Regional Dermatology Training Center in the northern part of Tanzania is training a lot of dermatologists, and having them be part of the partnership would be the ultimate goal. But I think you all sort of strike on a lot of the things. I think the main goal is to sort of have access to care, but having something that's sustainable and sort of taking care of patients over the longer term.
Can I just piggyback on what Carrie said? That I used this analogy early on in the pandemic, that first you want to get the lights on, and then you can pick out your favorite chandelier later on. You really just want to figure out the easiest, simplest way to make it happen. And using apps like Carrie, and I know others like Tori Williams have used, like WhatsApp, that's something that's so widely accessible, and it's actually encrypted and everything, that it's just using whatever you have before you overinvest resources in a strategy that might not work. So first proving proof of concept, and then when you have buy-in, local buy-in, like Carrie said, then building upon it.
Mm-hmm. We do have a couple of questions coming in, but before that, I'd like to bring in Eugene. So Eugene, you compared in-person to teledermatology diagnoses when the consultations were with dermatologist 1 by Telederm and dermatologist 2 by a different dermatologist. Have you compared in-person diagnoses and management? So we did this sort of study quite a long time ago, but we're very conscious that I might give a condition a name. I might call it atopic dermatitis, and my friend calls it atopic eczema. Of course, it's more complicated than that. Have you actually compared whether your colleagues do make similar diagnoses and management plans?
Hi, Professor Oakley. Like everyone else, I'm very pleased to be here, to be part of this conference and to meet everyone here today. Right, just to answer Professor Oakley's question, I mean, in our study, our internal study, we tended to group similar diagnoses together. For example, whether you call the patient as having endogenous eczema or atopic dermatitis, we still classify it as the correct diagnosis, just eczema. No, it's not like mycosis fungoides or something else.
Mm-hmm. Fair enough. Look at our first question here, because I think it's really important, and one of the reasons that not every dermatologist is keen on teledermatology is the matter of reimbursement, and we all do it our own way. So here in New Zealand, I'm salaried, but I'm allocated time to do my referrals. Not enough time because we've got 200 people waiting, so that's a week behind. So we've just created a new waiting room. So much for people saying you can get back in 20 hours or 2 hours. We used to be able to do that too. but the GPs aren't reimbursed. So they have to charge the patient for any extra time. So in New Zealand, GPs have to charge patients, and the charge depends on whether it's a child or an old person or a working person, because they have capitation fees as well. But the GPs grumble because they either have to absorb the costs of an extra 15, 20 minutes, or they have to charge the patient. So Eugene, tell us about reimbursement in Singapore.
So basically, Professor Oakley, at the place where I practice, which is the National Skin Center in Singapore, we actually charge patients similarly, whether they come for teleconsultation or whether they come for in-person consultation. So I think the advantage for teleconsultation is that although the consultation charge is similar, but they actually save money on transportation. They actually save a lot of waiting time in our clinic and at our pharmacy.
That's true. And you're salaried yourself?
Yes. I mean, our doctors are salaried. Yeah.
What about Jules?
Can you restate the question exactly how I'm paid for?
Reimbursement for your end, and what does the patient pay? And so on.
Well, as far as our practice, and I don't want to suggest that our practice is ideal, but we have been able in the United States, at least, for video visits to get parity. So basically, the visits are billed the same as in-person visits. There is some payment available for store and forward share digital photographs, but it is very poor. And in our survey, I mean, it's something like $10, $15 a consult, something like that. And that's not really sufficient to cover the overhead and everything for providing that service. But that's the only system that we have set up. And I don't think it's ideal. And I think how I always envisioned things was to be more store and forward based. And I think an ideal system would find a way to appropriately value that and charge and even account for all the inundation of messages and photos patients send us in a way that is compensated for.
Yes, because teledermatology, even store and forward, can take just as long. I could spend half an hour looking patients' blood tests and the previous drugs and so on before I compose an answer. So it's not just a quick yes, or what you might, a chat you might have with a family member. Christian, what about in Germany? How's the reimbursement for teledermatology going there?
I think as you mentioned before, this is one of the major issues if it comes to telemedicine, to get the reimbursement. For Germany, Switzerland, Austria, I think it's very easy to say if you're in a video consultation, means synchronous teledermatology, there are ways for reimbursement. If you're performing asynchronous, so store and forward teledermatology, so far there is no regular reimbursement. There are some contracts with some health insurances, but in general, this is a self-payment service for our patients. But patients do pay for it. So we have thousands of patients within these countries paying for these services. And it's also a chance for doctors to offer services for an amount of money where they, in the end, get also some outcome out of it. And I made a first economic study on this for one of the major university hospitals in Switzerland. And we could actually show that with a price and the self-payment by the patients and the average loan of a doctor, we could in the end also show some income for the doctor, or in this case for the hospital.
That's good. And in Europe, I think you are based in Switzerland, aren't you?
I'm sitting in Zurich, but yeah. I can speak at least for Switzerland and Germany. Yeah.
Right. But every European country does it their own way. In fact, that's true all over the world. And we have different health systems, and what works in one place is not going to work at all in another.
It's not only the reimbursement. Yeah. So in Europe, you have too many small countries with too many laws. So for a small company who wants to push teledermatology, for example, it's very tough to expand, because for every country, you really need to figure out what is the rule in terms of reimbursement, in terms of liability, in terms of online consultations. Actually, in Germany, it was not allowed to make online consultations until 2018. It was forbidden. So it's really tough, especially if you start in a very small country like Switzerland. It's a good country to start, but I mean, you need to expand to get a bit of better and bigger market.
Yeah, well, it's happening slowly with more sophisticated systems coming in. And Carrie, what about your experience of reimbursement?
Well, all of my collaborations in terms of Africa are all voluntary, so there's zero reimbursement. It's a reimbursement of seeing patients get better, I guess, in terms of that. And then I feel like my experience in my regular practice is very similar to Dr. Lipoff's, where we basically our live interactive visits are reimbursed at the same rate. Same thing with a store and forward. Messages that we get, or through the electronic medical portal that we get a lot of images and things that are oftentimes either not reimbursed because it's not set up as a separate visit or not. I feel like part of your question also had to do with the primary care providers, and we found that similar frustration. We have a store and forward platform that we wanted to incorporate within our electronic medical record. And even if we as dermatologists were reimbursed a very little bit, the primary care doctors weren't very excited about it because it would be provider to provider. They would have to institute the plan. And so it's actually creating more work for them as opposed to them just referring them for a dermatology consultation themselves. And so we have found some frictions from the primary care providers because it takes additional work in their care of patients. So I don't have a great solution for that, but I feel like we need to be a little bit more creative in terms of how we think about reimbursement of this if we want telemedicine, and teledermatology to be a sustainable, effort within the United States at least.
So in New Zealand, we have very few dermatologists, and our hospital clinics are also very few. So we are burdened with hundreds of outpatients for whom we have no appointment. So literally 2,500 people waiting for appointments and nowhere to put them because we're fully booked till the end of February. So we're doing telephone consults, but mainly we're transferring the burden to the GP. And instead of seeing patients in a month's time, we're saying, we'll see you in a year's time, go and see your GP. And the GPs are complaining, we can't handle this. We're not trained in the use of methotrexate. We're not trained to, and we're not paid, and the patient doesn't turn up and they won't have their blood test done and so on. So it's very challenging with the increasing number of patients presenting with skin diseases all over the world, and increasing age and diabetes and obesity and all the new world things, even beside COVID. Now, we've got a completely different question here. We've talked about lack of access to the internet and how sometimes a cellular a system of communication works better. Well, it wouldn't be working on my cell phone today because I upgraded to the latest iOS 15, and now none of my cellular works on the phone. All I can do is use it as a telephone. So, and I haven't managed to fix that. So this question is regarding 5G. So is 5G, is that going to be better for teledermatology? Personally, I have no opinion. We don't have it yet.
From my point of view, I don't think we need 5G. I think existing internet, at least in German-speaking countries, most areas are enough. But I think we need good, we need at least, I would say, I'm not too technician about this, but 2G, 3G to make it happen. As I said, like when I went to Ethiopia, it wasn't even possible to open Google. It wasn't even possible to open Google from the main website of the office of the senior consultant dermatologist. He couldn't open his browser and put in Google. I mean, now if we're talking about 4G, 5G, about mobile internet, but also if we have the normal internet, we really need a standard, but it doesn't need to be high end, I think, neither for video consultation nor for store and forward technology.
What about in the States and Singapore?
I would say that I think a lot of this has to do with how efficiently we're using our resources. Do we really need to use the bandwidth for a video visit for something like acne? Is that really necessary? Whereas certain conversations might require that. Or is there a way to triage it so that I don't think we need it for the most part to have any like sophisticated bandwidth, but I think if we are really triaging and maybe even using things like augmented intelligence to help with the triage, there may be ways to more efficiently use whatever limited resources we have and do just as good a job.
Yes, so we don't need new top technology, but once we've got it, we're probably quite grateful to have it. What about in Singapore?
So in Singapore, right now we are using mainly 4G. I mean, our mobile phones are predominantly 4G phones. We are starting to have some 5G phones in the past few months, but I suppose it will take maybe another 1 or 2 years for usage of 5G to really proliferate in our population. I mean, personally, I feel that store and forward teledermatology doesn't require a very fast internet connection. So probably like 3G or 4G is sufficient. Whereas if you really want to do video teleconsultation well, I would think that having 5G might be potentially useful, or at least a very fast broadband connection, so that we can actually transmit a higher quality video, like at least a 1080 resolution, instead of using a lower quality video resolution, because that may really help diagnosis and looking at the patients over video, in addition to whatever still images that we get from the patients.
Yes, there's nothing like the plain old telephone system as well. Only most people have given up their landlines, and getting people on mobile should be easy, but somehow it isn't. A lot of people don't pick up from an unknown number, for example, even though they're expecting a call from the hospital, because they're scheduled. Okay, so we're just in the last couple of minutes. Any burning question in the last minute and a half from my panel members? So we have a comment about 5G from Dr. Begons. 5G will be good in case of users of devices 10MT or telesurgery when you really need precision and no delay. Maybe the connection will be better and faster. But, okay, there's lots of buts, aren't there, in Telederm. We're looking forward to it becoming work as usual. Thank goodness for COVID. It's been a terrible, terrible scourge, but it has helped teledermatology. So I'd like to thank my panel members. That's Jules from the States, Kari from the States, Christian from Switzerland, and Eugene from Singapore. And to hand over to the next session, which is session 6 of the Congress. I'm Amanda Oakley. I'm a dermatologist in New Zealand. I'm president of the International Society of Teledermatology. And it's been a great pleasure to talk about global teledermatology with you all. So enjoy the rest of the panel session. Those of you who've had difficulty in reading Christian's presentation, I believe a new version has been uploaded, and hopefully that one works better than the first version. Okay, so many thanks.